muscles for the pumping of the heart. So so then it means when you are, and why we need to paralyze this patient when you're doing such surgeries is that we need that the surgeon can have a good working environment, because when the patient is breathing on their own, you find that the gut, the intestines tend to get out, to pop out. And remember, like the surgeon is looking for the appendix, like, the surgeon is looking for where the problem is. So we need to paralyze the patient so that we can stop the breathing. When the patient breathes on their own, then the breathing cannot be controlled. Yeah, they might decide to take a deep breath or a shallow breath. But when we give muscle relaxants and take over the respiration of the patient, then we are able to control the rate at which the patient breathes. That is the respiratory rate. We are also able to control the rhythm. Okay, so that we can know whether we want this patient to breathe shallowly, we want this patient to take deep breaths, but not the patient to decide on their own. Okay, and so this one now helps the surgeon to be able to have a good working environment. And also you also need that muscle relaxation, so that you can be able to retract the muscles and be able to, the surgeon will be able to see whatever it is that he wants to see. The other point, reason why we want to paralyze a patient is that, the work of breathing. I mean, breathing is work. Okay, that needs energy and all that. So we want to take over the breathing of the patient, so that we can rest the respiratory muscles, so that by reducing the work of breathing. So that's again another reason why we want to paralyze the patient. And remember, uh, this would be important, especially in surgeries that take long. Yeah, you don't want the patient breathing for that long, and they are asleep, so you want to take over the work of breathing. So then, to be able to do that, then you need to paralyze the muscles. And to be able to paralyze the muscles, then you use these drugs we call the neuromuscular blockers. I hope you can see the screen. You can see the slides.
Yes.
Okay, yeah. So today we are going to discuss the neuromuscular blockers, and to be able now to understand how the neuromuscular blockers work, then we need to be able to remember the anatomy of the neuromuscular junction, how the neuromuscular junction works, and we also need to understand the physiology of the neuromuscular junction. Okay, so I want to imagine that now, while there, you can be able to visualize, yeah, from your to the acetylcholine, which is removed immediately, and another contraction comes, and a relaxation and a contraction. So we say that so this depolarizing muscle relaxant will cause a contraction initially, but then they continue to occupy the receptors, and the muscle becomes electrically unresponsive to further stimulation by acetylcholine. Because, like I was explaining, another class cannot come and get into that class when you are there, because they will even have nowhere to sit. So we say that this action persists until the depolarizing relaxant is hydrolyzed by acetylcholine, and this one takes a few minutes. Okay, so that's how a depolarizing block works. Okay, then we have the non-depolarizing block, whereby, so these drugs, now when you give these drugs which do not cause a depolarizer, that these drugs, they combine with the receptor and they prevent acetylcholine from getting to the motor end plates, and they don't cause any contraction. So there is no depolarizing. The depolarizing is actually the and then acetylcholine cannot now come back and occupy. So there is not going to be any contraction until this drug is removed. And we're going to see that these non-depolarizing drugs, they stay longer. Actually, we call them long-acting muscle relaxant because they stay long on those receptors compared to the depolarizing blockers. Then now, what is a dual block? A dual block will occur if you give repeated doses of a depolarizing drug. And the depolarizing drug that we're going to talk about is a drug we call suxamethonium. We also call it succinylcholine, and we also call it in short scoline. And sometimes in the notes you just find us just writing sux. So when you see sux, scoline, suxamethonium, succinylcholine, all that is the depolarizing block drug that we have. So we say that maybe you give 100 milligrams of suxamethonium, then maybe immediately you give another 100 milligram or 50 milligrams. What happens is that now this depolarizing block becomes so it means that this drug will stay longer in those receptors, causing what we call a dual block. So like you have a phase 2 block. So we have, when you give one dose, you call it phase 1 block. But when you repeat doses, the same drug acts differently and produces a non-depolarizing block. Okay, meaning that it stays longer in those receptors. Then there is what we call a mixed block, and a mixed block will occur when you give, like I give an depolarizing block, for example our suxamethonium, then immediately before the suxamethonium wears off and the patient starts to breathe, I give a non-depolarizing block. So what happens is that then the patient gets what we call a dual block, or a mixed block, and this one may take longer before the patient can recover from the muscle paralysis. So those are the 4 types of blocks, but mostly we'll be dealing with the depolarizing and the non-depolarizing block muscle blockers. But those are the drugs that we'll be discussing when we discuss muscle relaxants. So that now then, because we've understood what is what happens at the neuromuscular junction and what happens in normal circumstances, then it's important to understand what happens when we give these drugs that cause depolarizing block and those drugs that cause non-depolarizing block. So all these drugs, we call them muscle relaxants. They relax the muscles, they paralyze the muscles. So then what are they used for? So these muscle relaxants, they are used for, one, to facilitate intubation of the trachea. Remember that time I came with some teaching aids, when I came with the remember when I came with the laryngoscope, I came with the breathing circuit, and I was telling you that when you give intravenous anesthetic, at times you're called upon to put an endotracheal tube. An endotracheal tube is that goes through the mouth or through the nose into the trachea, so that you can give gases, oxygen and the volatile anesthetic through that tube, because we say they are inhalational. So for you to be able to put that tube, what we call intubation, then you need to relax the patient, because when you only give the patient the induction drugs, the propofol, the ketamine, or the sodium diobendone, the patient will sleep. But some patients sleep with their mouth closed, with the teeth closely, tightly closed, so that you cannot be able to open the mouth. Remember, I said introduce the laryngoscope, then put the tube, so you cannot open the mouth. So for you to be able to open the mouth, then you have to paralyze the muscles. Remember the muscles around the mouth, so that you can open the mouth and put the laryngoscope and then put the tube. So we see that these muscle relaxants, one of the function is they are used to facilitate intubation of the trachea. Then the other thing is that they are used to facilitate mechanical ventilation. Let's say you have this patient whom you want to ventilate, to mechanically ventilate, whom you want to take over their breathing, because there are some patients, because of their condition, maybe for example, patient is asthmatic, they are not getting enough oxygen, so you want to be able to breathe for them. You want them to put them in the ventilator in ICU, then you have to paralyze them. Because if they are not paralyzed, then they are doing they'll be doing what we call fighting the machine. They'll be fighting the machine. The machine is trying to breathe for them. That is the ventilator. So the ventilator will be trying to breathe for them, and they also try to breathe for them. So we say that this patient is fighting the machine. So for us to be able to stop the breathing of the patient, so that can be done by the machine, then we give muscle relaxants. Then the other use of this muscle relaxant is that they optimize surgical working condition. Remember, I've told you for surgeries in the chest, in the abdomen, the surgeons need to have a good working condition where the muscles are really relaxed. He can retract them and get to whatever organ that he needs to work on, especially for surgeries like laparotomy, surgeries like thoracotomy, where you have to stretch the muscles between the ribs so that you can get into maybe the lungs or the heart where you are working on. So that's the other use of this muscle relaxant. So there are those three uses of muscle relaxants. One, to facilitate intubation of the trachea. Two, to facilitate mechanical ventilation. And three, to optimize the surgical working condition of the surgeon, especially when you're doing laparotomies and surgeries around the chest. So then the other question is, how skeletal muscle relaxation, how can you achieve skeletal muscle relaxation? How can you make sure that the muscles are relaxed? If you give high doses of muscle relaxant, of them can cause muscle relaxation. So if you give high doses of allodine, it can cause, remember we saying that when you go like to stage 3, plane 3, 4, you start getting paralysis of the respiratory, the intercostal muscles and the diaphragm. So if you give high doses of this volatile anesthetic agent, you can achieve muscle relaxation. The other way you can achieve muscle relaxation is by giving regional anesthetics. We're going to be discussing local and regional anesthetics. So you'll see, just like I was explaining, that if you block this patient, so there's no going to be any activity at the neuromuscular junction. So then it means there will be no muscle contraction, so there will be muscle relaxation. And the other way you can do is what we are discussing now. You can administer the neuromuscular blocking agents. So those are the three ways you can achieve skeletal muscle relaxation. Then something else we should know is that you cannot give muscle relaxant if the patient is not unconscious. Okay, so we say that muscle relaxation must not be given without adequate doses of analgesic and hypnotic drugs. Sorry. So then it means I cannot give you muscle relaxants when you are awake. Okay, I have to make sure that you are adequately anesthetized, or you are adequately asleep or unconscious. And also, it's also good to understand that it doesn't mean that when the patient is relaxed, the muscles are relaxed, that the patient are not feeling pain. Okay, these muscle relaxants, they block the motor function. Okay, they block the motor function, not the sensory function. So the patient will be paralyzed, but they are feeling pain. They can hear you talk, but they cannot respond because the muscles of speech are paralyzed. They cannot lift, or even, the way you would want to withdraw, or even have some movement to show that you feel in pain. They will not do that, but they will be feeling pain. So it means then before you give any patient muscle relaxants, you have to give them hypnotics, or those drugs we say that they cause unconsciousness, and analgesic. Because we say that if muscle relaxants are inappropriately given, you'll have a patient who is paralyzed but not anesthetized. And it is very dangerous. You can imagine you are there, you are not asleep, but you are paralyzed. You cannot say anything, you cannot move. It's usually very depressing to the patient. So then what are these muscle relaxants? So we see that we have the depolarizing muscle relaxants, and we have the non-depolarizing muscle relaxants. And we have said that we only have one depolarizing muscle relaxant drug. One drug I've said we call it suxamedonium, succinylcholine, scoline, or sux. Just that. So that is the drug. It's just the same drug. It's the one we use to give depolarizing muscle relaxant, and they are usually short acting. Suxamedonium is a short acting muscle relaxant. Normally we use it for intubation. So like, there are some patients you want to put an endotracheal tube, but you want the patient to breathe for them. So let's say, for example, the surgeon is working on the leg. They don't need any muscle relaxation. So you just intubate the patient. Within 5 minutes, the suxamedonium wears off, the acetylcholine starts binding, the patient starts breathing for themselves, and then the surgery continues. So the patient will be anesthetized, but they are not paralyzed after the dose of suxamedonium has worn off. Then now then we have non-depolarizing muscle relaxants, and the non-depolarizing muscle relaxants are divided into two groups. They are classified into two classes, and one of the classes we call it benzylisoquinolinium. Benzylisoquinolinium is one of the classes, and then we have another class we call aminosteroids. So we have benzylisoquinolinium and aminosteroids. These two classes can also be classified in terms of the duration of action. So you can say long acting, like you can say you have a long acting benzylisoquinolinium, you have an intermediate acting benzylisoquinolinium, or you have a short acting aminosteroids. So these two classes, the drugs in these two classes can be classified into either long acting, intermediate, or short acting. Let's look at the depolarizing muscle relaxant, which is succinylcholine or suxamedonium. And so we ask ourselves, how does it work? What is the mechanism of action of suxamedonium? And we say that this suxamedonium, or this depolarizing muscle relaxant, they physically resemble two molecules of acetylcholine. Remember, we have said that they work much like acetylcholine. So we say that suxamedonium, it resembles acetylcholine because it is made of two molecules of acetylcholine. So we say that it acts as acetylcholine receptor agonist. So it works just like a acetylcholine. It is not metabolized at the neuromuscular junction. We say that acetylcholine is metabolized, or in other words, it's hydrolyzed by acetylcholinesterase. Remember when I was telling you to write that equation of, you write acetylcholine, give you acetate and choline, and we see that this breaking down of acetylcholine into acetate and choline is catalyzed by acetylcholinesterase, which is an enzyme. Acetylcholine, succinylcholine is not hydrolyzed, or it's not metabolized locally at the NMJ. So what happens is that this succinylcholine is metabolized by an enzyme we call pseudocholinesterase, which is usually found in plasma. Please note that the acetylcholinesterase that hydrolyzes acetylcholine is found at the synaptic cleft. So it is just there. So acetylcholine binds, does its work, immediately it is broken down. But for succinylcholine, the pseudocholinesterase receptors for at least 5. So we can say that the duration because we say that it works, initially it works like acetylcholine. So it means you're going to get a depolarization. The sodium ion channels will open, sodium will move into the cell. There's going to be action potential will be generated, and threshold will be reached. Than mostly for intubation, that you can paralyze the patient for a short time, put in the endotracheal tube, and then within 5 minutes the patient starts breathing again, and you can let them continue to breathe, and the muscles now become they are not relaxed anymore. So then what is the dose of succinylcholine? It is 1 to 1.5 milligrams per kg body weight. So you can give 1 milligrams, like if a patient is 50 kgs, you give 50 milligrams per kg, or if you decide to use 1.5 milligrams, then you give 75 milligrams to that patient. That is when you give it intravenous. Sometimes we can give it IM, which is not common. Then the dose increases to 3 to 5 milligrams per kg body weight. The onset of action, after you give the drug, within 30 to 60 seconds, the patient is paralyzed. You'll see the fasciculations, then the patient paralyzes, and that time you're able to open the mouth. Okay, and we say that the duration is between 5 to 10 minutes. After 5 to 10 minutes, the patient starts breathing again, and the paralysis is no more. So then again, it's also important to know that there is no drug. It's no drug without side effects or adverse effects. So so these are the side effects of succinylcholine, which we can also call suxamedonium, and one of them is bradycardia. So suxamedonium lowers the heart rate, especially in kids, and especially when you give repeated doses. So if you have to repeat the dose of suxamedonium, then you'll be worried of bradycardia. So most of the time when you want to repeat, we combine it with some cholinergic. We combine it with atropine, so that atropine increases the heart rate, so that we counteract that um, bradycardia. Then the other side effect is muscle pain. We've said that it causes a contraction. So this patient, and we say that you're going to see what we call the fasciculation. So normally because of that fasciculation, when the patient wakes up, they complain of muscle pain because of that pain, especially young fit adults, especially when they start mobilizing early after the surgery, they will complain of muscle pain. The other things side effects are increased intraocular pressure. So the pressures in the eye increased intragastric pressure, increased intracranial pressure. So those three, for example, if you are asked what are the side effects of suxamedonium, at least you should at least remember that it increases most of the pressures we know. Pressures in the eye, the intraocular pressure, increases intragastric pressure, that is pressure in the stomach, and increases the intracranial pressure. It may cause anaphylaxis in some patients, and then you may get a prolonged block. Okay, instead of taking the 5-10 minutes, it may last longer than 5-10 minutes. And normally this occurs in patients who have reduced plasma chorinesterase activity. So let's say genetically a patient has a reduced amount of plasma chorinesterase, then it means whatever amount is there will take longer to remove the suxamedonium from the binding site, so the block might take long. Okay, then the other side effect is hyperkalemia. Okay, hyperkalemia, it increases the potassium levels. So there are some patients we don't use suxamedonium. One of them is a patient with burns, a patient with pre-existing burns. After 40, maybe a patient has got burns. After 48 hours of the burns, up to 3 months, we don't give suxamedonium. Why? Because of the hyperkalemia. Why burns and hyperkalemia? We've just said that potassium is inside the cell. So what happens during burns is that you destroy the cell and you destroy the membrane of the cell, so that, and when the membrane is destroyed, we know that potassium will move out of the cell. So meaning that the extracellular compartment will have more potassium. So meaning that a patient who has burns has hyperkalemia, because the potassium inside the cell moves to the blood. Yes, because the membrane has been destroyed. Or even a patient with muscular dystrophies, issues with muscles, you find that they usually have hyperkalemia. So again, you don't want to give them a drug that causes hyperkalemia. And we know that Hyperkalemia can affect the heart and can cause even a cardiac arrest. So anybody with spinal cord injuries, anybody with existing burns for 48 hours, anybody with muscle dystrophies, we don't give suxamethonium. It is contraindicated. So it is a side effect. Hyperkalemia is a side effect. So if we have a patient whom we think due to any of these things we discuss here, the burns, the muscular dystrophies, the spinal cord injuries, may have hyperkalemia, then you want to withdraw suxamethonium from. Then the other one is malignant hyperthermia, and I'm sure I talked about malignant hyperthermia when we were doing the pre-anesthetic review. So these are the side effects. So bradycardia, muscle pain, it increases all these pressures, the intraocular, intragastric, and intracranial pressure, may cause anaphylaxis, and may cause a prolonged block, especially in patients with reduced plasma chorinesterase activity, because we said plasma chorinesterase or pseudochorinesterase, which is found in blood, is what hydrolyzes or what helps to remove the suxamethonium from the acetylcholine receptors. So that is depolarizing muscle relaxant. Like you told, write short notes of depolarizing muscle relaxant, and next equation of 15, or discuss as discuss depolarizing muscle relaxant. Then of course you need to talk about the what it is, the mechanism of action. You need to talk about what are the uses. You may need to talk about the dose, talk about the side effects, and you'll be able to get your marks. So then we go to the non-depolarizing muscle relaxants, and again we start with the mechanism of action.
Excuse me.
And this, yes, yes,
We cannot
you cannot.
we cannot see your slides. You're not projecting.
From when?
From the discussion on succinylcholine.
Okay, but you are understanding what I'm saying. You are understanding what?
Yes.
Okay, let me see what's happening. Doesn't want to see. Sorry, I think there's a problem with the share button. Oh. Okay, I think there's a problem with the share button. I don't know what has happened. It is not highlight. Yes, Maureen. Let me log out when I get to. You can see the slides now.
Yes, yes.
Yes. Anyway, let me just finish this so that I think it's also getting late. So now then, so the mechanic. So how do this? So now we talked about the depolarizing. Now we go to non-depolarizing, and we are saying what is the mechanism of action. And remember, we have said that this non-depolarizing mass or relaxant, they compete with acetylcholine at the binding site. They don't work like acetylcholine, but they compete. Okay, it's a way like, again, when you use the classes, it's a way like when you wake up in the morning on Friday and you find the nursing students in your class, you know that the nursing student compete with you for that lobby one. Yes, but you are different, you know. Maybe so we can compare the non-depolarizing muscle relaxant to the nursing student. Suppose you find the ideas. You guys are for the you are for the yes. Suppose you find the second years in your class in the morning, then we can say those are depolarizing muscle, because you know it is the same school. So now we can say that as non-depolarizing muscle relaxants, they compete at the binding site with acetylcholine, the way nursing student, and you know, even sometimes you saw their teacher coming to tell me, you know, I should be the one in class. So it's like we compete to be in that class. So they compete, but we don't work the same. You know, you're not doing the same course with the nurses, but you compete for that class. So what these non-depolarizing muscle do, they do not depolarize. They do not cause any contraction on the muscle. Nothing happens. They just bind to the receptors and nothing happens. The muscle just becomes dead. It becomes paralyzed, nothing happens. So they act as competitive antagonists. They act as competitive antagonist. The suxamedonium act as, we say that they are competitive agonists because they work the same. So we say that excessive concentration causes channel blockage. So if there is excessive, so like if all the receptors are occupied by this non-depolarizing mass or relaxant, so then the channels are blocked. There is no movement of sodium into the cell or potassium out of the cell. So there is no depolarization. And we say that this non-depolarizing mass or relaxant, they even work at the presynaptic sites. Yeah, they work at the presynaptic sites. You see, they work here. They also, in addition to binding on these sites, they will also work here to prevent acetylcholine from getting out of the synaptic knob into the synaptic cleft. So you see, they have two actions. One, they will bind on they competitively bind on the receptors, and number two, they also prevent acetylcholine from moving from the synaptic neuron into the synaptic cleft. So they have two ways of really blocking this acetylcholine from binding. Okay, so they competitively occupy the receptors where acetylcholine should be occupied, and they also prevent acetylcholine from moving to the release sites in the presynaptic sites. And you see that there are two groups, or there are two classes, and one of them is benzoyl-isoquinolinum. And these ones, they are more liable to break down in plasma. This benzoyl-isoquinolinum, they can be broken down in plasma, but after some time. And then the other thing about them is that they release histamine. All of them except one of them, which is cisatracurium, they release histamine. So what does that tell us? Any drug that releases histamine, then it's not good for asthmatics. Okay, so we can say that all of them except cisatracurium, they are contraindicated in in asthmatic patients. So what are examples of benzylisoquinolinum? One of them, tuberculare, and this is a drug which has been phased out. We don't use it anymore because it had a lot of side effects, especially in the kidneys. So what we are using mostly now is atracurium. Actually, atracurium, we use it most of the time as a long acting, or as a non-depolarizing mass or relaxant. The other one is cisatracurium, and the other one is mifacurium. These ones are in the class of benzoylisoquinolinum. And we say that they may be broken down in plasma, and we're going to see later what this means. Okay, if they can be broken down, meaning because we're going to see the other group, which is aminosteroids, you have to reverse them. If you don't reverse them, then the patient may reverse, go to the ward, and then the receptors are occupied again, and the patient stops breathing. So it's not nice. So that's the difference between the benzoylisoquinolinum and the aminosteroids. Then again, so we have now the other group is aminosteroids, and this one do not cause release of histamine, so they are good for asthmatics or patients with issues with allergy. And then these ones are also they are metabolized in an end organ before they are excreted. So they are metabolized like in the liver and then excreted in the kidneys. An example of these aminosteroids are pangilonium. Pangilonium, we also used to use it a lot before we got atracurium, and we still have it in some places. It's also it's a good drug. It's a long-acting muscle relaxant, especially for long surgeries. Then we have feculonium and we have rocuronium. So these are aminosteroids, but they're in the class of non-depolarizing muscle relaxants. Then we say that all these, the aminosteroids and benzoylisoquinolinum, can be classified into their duration of action. So we have the long-acting. Pangilonium is one of the longest acting. Then we have the drugs that are immediate acting. It's atracurium, is a benzoylisoquinolinum. Then we have feculonium, rocuronium, and cisatracurium. And we have another short-acting short-acting benzoylisoquinolinum, mifacurium. Maybe when you don't have suxamethonium, or maybe in patients with burns and those muscle dystrophies, you can use mifacurium to intubate. So pangilonium, we just go through a few of these. Pangilonium is an aminosteroid, we've said. The onset of action is 3 to 5 minutes. The duration of action is 60 to 90. So it takes like 1 hour to 1.5 hours. You don't need to repeat. If the surgery takes about 1.5 hours, you just need to give a single dose and the patient will be paralyzed. If you have to intubate with them, the intubated dose is 0.08 to 0.12 milligrams per kg. Normally comes in ampules of 4 milligrams in 2 ml. It's eliminated mainly in kidney, 85% of it unchanged, and 15% is metabolized in the liver. What are the side effects? It causes hypertension. So again, it's not good for patients who are hypertensive, causes tachycardia, and may cause dysarrhythmias. The other one is feculonium. It's an analog of pangilonium, much less, it has much less phancolytic effect and shorter duration of action than pangilonium. So meaning it doesn't have this hypertension, tachycardias. So it's better when it's better if you have nothing else in a patient who is hypertensive. It's better to use feculonium. The dose is the same as that of pangilonium. Again, metabolized in the liver to active metabolites, and 40% excreted in urine and 60% in the bile. Then we have another aminosteroid, which is rocuronium. Again, this one is an analog of feculonium. It has a rapid onset of action, which is 1 to 2 minutes. Remember, these others have 3 to 5 minutes. So this one is a faster onset of action. The duration is 20 to 35 minutes. And this onset of action again is also similar to that of suxamethonium. So again, you can use it for intubation, because for intubation again you need a drug that has a faster onset of action. Remember, we said sux is between 30 to 60 seconds. The intubating dose of rocuronium is 0 to 6 milligrams per kg, and it's metabolized primarily in the liver. So meaning then a patient with liver disease, liver issues, you don't want to use rocuronium, and it's a slight amount of it is excreted in the kidneys. So then we go to the benzoyl-isoquinolinum and you have trachurium. We said we using most of the places, everywhere it is being used. It's a metabolized by what we call ester hydrolysis. Actually, it undergoes something we call Hoffman's elimination. Maybe you can go. It's a process. It's a long process which I don't want to go into this for you. But if you're interested, you can go and read what happens in Hoffman's elimination. The onset of trachurium is 3 to 5 minutes and it takes about 25 to 35 minutes. And this is the intubating dose. You give 0. If you have to intubate with it, you give 0.5 milligrams per kg. But normally, even for maintenance of that paralysis, we just give 0.5 milligrams per kg. And these are the side effects that it releases histamine and they cause hypotension, tachycardia, and bronchospasms. And also may lead to this laudonosine toxicity. It produces this substance we call laudonosine, which may be toxic to the patient. Cisatracurium is also an isomer of atraculium. It's also metabolized by this Hoffman's elimination. Onset of action like that of of atracurium, duration the same, but the dose is 0.1 to 0.2 milligrams per kg. It has minimal cardiovascular side effects, but much, and also produces much less of this laudonosine compared to cisatracurium. Then there are some factors that may alter the response of these drugs, like the temperature. So you find that like if the temperature patient is hypothermic, the response of this drug may be altered. Or patient who have acidosis, patient with electrolyte abnormality like hypokalemia or hypermagnesia or hypocalcemia. Age again may also make you maybe reduce the dose. These are factors that may help you, may make you reduce the dose of the drug or increase. Age again, of course, we find that in the young and in the older patients, you want to reduce the dose. And also concurrent disease, maybe patients with muscular disease or patients with liver or renal. Remember, these drugs are either metabolized in the liver and excreted in the kidney. So if a patient has liver or renal disease, you may need to reduce the dose or even not to use it at all. Then also we may get drug interactions. So these muscle relaxants may interact with other drugs. So, and again, patients with concurrent disease, like patient neurologic disease, muscular disease, liver disease, kidney disease, you may need to alter the dosage because of the altered response. Then the muscle relaxants interact with some drugs. They may interact with inhalational agents, intravenous anesthetic, local anesthetic, antibiotics, anticonvulsants, and even magnesium. So then again, you have to be careful in such situation, especially in patients who have other issues. Then again, we also usually monitor the neuromuscular function. You want to monitor whether the patient is really paralyzed. And where we need to monitor is that we need to be able to know that the muscle relaxant is wearing off. Because again, it doesn't mean that it stays, because you are saying the duration, like when you say the duration 25 to 35 minutes, then it means towards the end, the 35 minutes, the muscle relaxant now is wears off and is removed from the binding site. So acetylcholine will start to bind and the patient starts to breathe and the muscles start contracting. So then you need to be able to monitor the neuromuscular function so that you can give more doses. And also when you recovering the patient, or when you are reversing the patient, you should be able to demonstrate recovery by monitoring the neuromuscular function. So then how do you monitor the neuromuscular function? One of them is clinical signs. Like you can see the patient is moving, the, the, the body, is movement of the body, or you can see maybe like even you can use clinical signs, or you can use something we call a nerve stimulator. A nerve stimulator, you connect it to some muscle and you see whether there is movement. And a nerve stimulator is something which looks like I'm sure in physics you learned about something we call a galvanometer. So, and it has some like the hands of the clock, yeah, such that when there is any movement or any activity, then that hand moves. So that is a nerve stimulator. Or you can use clinical signs when you want like to know whether the patient has fully recovered from the muscle relaxation. Like you can tell them to do activity like raise your head lift, or lift your leg, and see whether they have they have recovered from the muscle relaxant. The other one is ability to generate negative inspiratory pressure at least 25. So in our machine, there's somewhere you can check. So when the patient is trying to breathe, you can see that generation of the negative inspiration pressure, or if the patient can swallow and maintain a pattern airway. Those are the clinical signs. And then, of course, there are other crude tests that we test whether the patient has reversed from the muscle relaxant. Like you can tell the patient to protrude the tongue, like lift your arm, like grip my hand, it helps us to know that the patient has worked. Then, of course, there is the use of nerve stimulator. I'll send the notes, you can read, but it's not important. Nobody will ask you at this the single twitch. Supposing now the surgery is over, how do you reverse this neuromuscular blockade? Okay, so you have, there are some other drugs we give to remove this drug, the suxamethonium. Usually the suxamethonium is usually hydrolyzed by the pseudocholinesterase, but the non-depolarizing, we all the time want to give drugs to reverse the action. And these drugs, we call them anticholinesterase. Remember, we say that cholinesterase, which is an enzyme, breaks down acetylcholine to choline and acetate. And so then if we can give a drug that prevents this equation, or this breaking down of acetylcholine, then it means that acetylcholine will accumulate at the synaptic cleft. Okay, it will accumulate at the synaptic cleft, and then because we say these drugs are competitive, if it accumulates, can be able to remove the drugs from the receptors. Okay, because we see that normally what happens when these receptors are occupied by the drugs, acetylcholine will be coming, because symbases will be coming, they will be coming, they get into the synaptic cleft, but then they are hydrolyzed immediately and they go back, they are broken down, they come, they are broken down. So if we can have a way of making this acetylcholine not be broken down, then it means they can accumulate in the receptors. Then again, a good example is again with our class. Okay, so then, for example, in the morning on Friday, you come and find the nursing student again. They come early and they've occupied your class. So normally you don't come to class, all of you. So you come like five, a group of five. They come and find the class as about 60 nursing students. So like maybe you go and tell them this is our class, then they tell you no, go get another class. Okay, so you normally stay outside there. So you stay outside there until you accumulate. Then when you are many of you, like the whole class had come, then you can go and push them out. Yes, unlike when they were just the 5 people could not push about maybe 50 nursing students. But if you are like even maybe 50 or 60 of you, you can push. So that's how, again, then as accumulation of acetylcholine does. So then, because we say that cholinesterase, the enzyme cholinesterase catalyzes the breaking down of acetylcholine, then it means if you give and drug that has anticholinesterase effect, it means then acetylcholine will not be broken down, it will accumulate around there, and it will be able to competitively remove acetylcholine from the binding site. So then what are we saying? So then to be able to reverse that neuromuscular blockade, you can give an anticholinesterase. And the anticholinesterase we use is a drug we call neostigmine. So when you give neostigmine, then it stops the breakdown of acetylcholine to acetate and choline, and then so acetylcholine accumulates there in in the synaptic cleft, and then it's able to remove these neuromuscular or muscle relaxants. So we give neostigmine, and we give at a dose of the onset of action. When you give it, within 3 to 5 minutes, the patient will have started breathing, and it takes about 45 minutes. It's around there for 45 minutes. It will be removed because it doesn't remove all the neuromuscular blockers immediately. So it removes, but it will be there for about 45 minutes. So we give at a dose of 0.04 to 0.07. Normally it comes in a vial of 2.5 milligrams. So normally in adult we give at least 2.5 milligrams. Another drug you can use is pyridostigmine or endrophonium. So these are anticholinesterases. So then how do they work? Just what I've explained, that they inhibit the activity of acetylcholinesterase. More acetylcholine is available at the NMJ, and they compete for sites on the nicotinic cholinergic receptors. And so then again, something else to know about this anticholinesterase, they have some muscarinic effects that neostigmine or the other drug will cause bradycardia. They increase the salivary secretions. They also increase intestinal tone, that the patient may present with diarrhea. They may cause meiosis, is that they constrict the pupils, and then they cause bronchospasm. So these are side effects of the anticholinesterase, the neostigmine. If you look at these side effects, they are the opposite of what atropine does. We know atropine increases the heart rate, it dries secretions, it reduces the intestinal tone, and it dilates the pupils. And I'm sure if you've worked in medical wards or even in casualty, and you've seen patients who come with organophosphate poisoning, they normally have these side effects. They normally have these. Okay, they will have bradycardia, they have increased secretion, they may have diarrhea, the pupils are pinpoint. So normally we give them atropine, and we should say give atropine this dose until full atropinization. That is until you get a good heart rate, until you dry the secretion, until the pupils dilate, and then there is no bronchospasm. So normally we combine, you cannot give neostigmine alone. We normally combine it with atropine to counteract the side effects of the neostigmine. So that's why you are saying we call them the muscarinic side effects of the anticholinesterase, and they are usually minimized by anticholinergic agents. Of course, this is atropine. So you give atropine at a dose of 0.1 to 0.02 milligrams per kg, or you can use another drug we call scopolamine, or you can use a drug we call glycopyrrolate. All these are anticholinergics. So what is the goal of reversal of neuromuscular blockade? It is to reestablish spontaneous respiration and the ability to protect the airway from the aspiration. So you want, when you give this, you want to reverse the neuromuscular blockade so that the patient can start breathing and they can protect the airway and protect it from aspiratory substances. Okay, so that is muscle relaxants. That's muscle relaxants. So I'm sure most of us have left, but not most of us. We're about 42. So I'll send the notes just now. I'm sure if you read maybe tomorrow or over the weekend, you'll be able to make some sense. Now, I might be away on Friday, I have a meeting in Nairobi, so I don't know if you within the week if you get another online class we can do. So Boniface, I don't know, is it Moses? Are you with us?
Yes, I'm there.
What about just I may not be in class on I have a meeting in Nairobi. Suppose
Yes.
you put the you collect the cat maybe on Friday on Thursday and leave it
Yes.
at with Jacinta. You can put in an envelope and leave it with Jacinta. Maybe I can pick it sometime.
Okay, it's okay. I will
Is it
collect.
possible to do that?
Yeah, I will collect.
Just collect it so that I can pick. Then maybe mark within so that I can give you by the end of the week next week. Then this is week. Which week is this? Do you know? Should be week about 7.
Yeah, it's week 7.
Okay, then we do a cut. We do a city cut just before. I think we'll do a city cut on the exam starts on 23rd, 4th. So we'll do a cut before the exam, a sitting cut, but I will let you know the time, the day of the cut. But it's good to just know that. We did what you did was the first cut. Usually, I usually want to have it take away, but we'll do a sitting cut of at least MCQs on some just before the exam, maybe a week before the exam, so that we can know how these exams look like. Okay, so let's see. If I don't have to go for the meeting, then I'll let you know. But if you can get another evening or even some early morning, you can let me know. But then again, or even next week, if you have a free, I don't know how many days are you in class?
We are only the only 2 days that we are in class.
Thursday and Friday.
Yeah.
So is your tomorrow? Do you have a free class?
Tomorrow we are busy. We have classes.
Okay. But
Yeah.
if you can get another online class before the other Friday, because we need to push you. I started the class, I think, on the 4th. Was it the 4th or that week? So that